Good evening, everyone. Thank you for joining our online CME live today from Gleneagles Hospital, Kota Kinabalu. My name is Lucy, and today we have Dr. Krishnan Sriram, our sessional colorectal and general surgeon, to share with us on common proctology problems in primary care practice. Before we start, allow me to brief you a little of Dr. Krishnan background. Dr. Krishnan completed his undergraduate medical training at International Medical University in year 2005. He then completed Masters in Surgery from University Kebangsaan Malaysia in 2013 before pursuing with subspecialty training in colorectal surgery. Locally, Dr. Krishnan completed his training at Hospital University Kebangsaan Malaysia and Hospital Tuanku Jafar, Seremban. He then went on with his overseas training in Taiwan and South Korea, focusing in laparoscopic and robotic colorectal cancer surgery. Dr. Krishnan is currently the head of colorectal surgery unit at Queen Elizabeth Hospital, Kota Kinabalu, and the only colorectal surgeon in Sabah for the time being. He performs most of his cancer surgeries laparoscopically and believes that minimally invasive surgery could help his patients recover much faster and continue with subsequent cancer treatment earlier. He is a strong believer of enhanced recovery after surgery and has a special interest in clinical nutrition. Dr. Krishnan looks forward to provide the best cutting-edge treatment for colorectal disorders in general and a holistic and ideal approach for colorectal cancer treatment for people in Sabah. If you have anything to ask Dr. Krishnan, please send it to the comment section and Dr. Krishnan will try to answer your questions towards the end of our session. And without further ado, I will pass this session now to Dr. Krishnan. Good evening, Dr. Krishnan.
Thank you, Lucy. Thank you very much for the kind introduction. And good evening, everyone. It's a great pleasure to be here talking to you guys this evening. Of course, everyone is busy with their own schedules and everything like that. But thank you for joining us tonight. Today, I'll be sharing a bit on the common proctology problems in primary care. This is something that I think everyone should know, and a bit of how to manage to a certain extent as well. And it's one of the topics that hardly being talked about as well. And just a bit of the outline. We'll just go into the bit of introduction, and then subsequently we will talk a bit of anatomy of the anal canal first, better to understand a bit of the diseases that we're going to talk about after that. Then we'll go a bit on the common presentation, how these patients actually present to us in the primary care, and what are the problems, what are the conditions that usually present after that as well. And finally, but not last, but I think we're going to go through a bit of the conclusion and take home message after that as well. And without further ado, talking about introduction part, anal or perianal disorders that we see in primary care takes up almost about 20% of all the surgical outpatient referrals. So that's quite a big number of patients that usually you see do come in with anal or perianal problems. And these problems are usually very distressing and embarrassing to the patients, and because things tend to be very sensitive to patients, so they don't come to us early. So they usually will come to us or come to see a doctor when the problem is a bit more mature or a bit more late. So it's good for us to know that, or counsel advise the patients on how to pick up early, if at all they should present early as well. And talk a bit of anatomy of anal canal. You see, the anal canal is roughly varies from individual to individual. So for males it's slightly a bit more longer, but for females it's slightly a bit shorter. But generally it's roughly about 4 centimeters. And when you talk about mid anal canal, the mid part of the anal canal where the dentate line is actually the junction between the anodem and ectoderm. If you look at the image, the line with the pink color line here is where the lower part with the endoderm, and this is basically where your endoderm, and this is the ectoderm is. And that's the dentate line which separates the two parts of the anal canal. And this is another picture which actually clearly shows us the anal canal. The upper part here where you actually see the upper part is actually the rectum. Yeah, this is actually the rectum, and this is the hausturations that you always see. Yeah, there are 3 hausturations usually in the rectum. This is first, second, and there will be another one on top. And if you look at the images here, this the papillus, what you see, the projections here that's just coming out, these are actually we call this a dentate line. Yeah, and yeah, the pectinates or dentate line, and the one you see on the side, 2 sides here, these are the sphincter muscles. Yeah, so the outermost layer that you see on the 2 sides coming in is actually the external sphincter. This external sphincter is actually a continuation of what we call of our pelvic floor muscles. Yeah, the pelvic floor muscle continues down as the external sphincter, whereas your wall of the rectum goes down, continuous, becomes the internal sphincter. Yeah, so external sphincters are usually voluntary, whereas your internal sphincters are usually involuntary. Yeah, this is just a bit of introduction on the anatomy part. Yeah, and if you look at the blood vessels, I think it's a bit too detailed, but what I would like to basically share is the blood supply that comes to the anus or rectum lobe is actually comes from the pudendal vessels, internal pudendal, which is actually a branch of the internal iliac. It communicates down here as well, and the venous part which is more important. It also drains back into the portal vein. Also from distally, it goes into the systemic vessels as well. So when the lower anal canal is diseased, the lymph nodes sometimes you also see along the where the systemic drainage happens rather than just the portal system drainage areas. Yeah, okay. And this is the nerve. This is also something that's very important. When I'll tell you guys later why is it so important. This is the nervation. So when you look at the anal canal per se, the upper part of the anal canal is the innervation is different compared to the lower part of the anal canal. The upper part of the anal canal usually by the autonomic nervous system, whereas in the lower part of the anal canal is usually by the somatic nerves. Yeah, so most of the time the procedures or whatever we do in the lower anal part of the anal canal is usually very painful for the patient because the somatic nerve innervations. Whereas the procedures or things that you do above the dentate line, patient don't feel it so much because it's by autonomic, so it doesn't carry the pain fibers so much. Yeah, so yep, okay. And we talked about earlier about sphincters as well. This is another diagram of sphincters, which actually shows that the external sphincters are continuation of the pelvic floor muscles. Your iliococcygeus, puborectalis muscle goes down to the lower part, becomes the external sphincters. Yeah, external sphincters again divided basically into deep, superficial, and subcutaneous. It doesn't really have so much of implication in the clinical part per se, but it's definitely, it all depends when you do surgery how much sphincters you want to cut in certain type of condition. It helps in that area. When you look at the internal sphincter, which is the pink line over here, the rectum comes down and it goes down into the internal sphincters. Yeah, and internal sphincters, I said earlier, are usually involuntary, whereas your external sphincters are most of the time is actually internal sphincters are involuntary, whereas your external sphincters are voluntary sphincters. Yeah, so it means basically you can actually control your sphincters. What we control sphincters is actually the external sphincters. Yeah, okay. So when you look at patients that comes to primary care practice, right, they can come with a variety of problems, issues, but some of the things that commonly seen in primary care practice or general practitioners is actually, first thing is bleeding. It's either from the anal bleeding, rectal bleeding, patient won't know. Yeah, so it's basically bleeding is one of the most commonest thing that you actually can see patient coming in. Yeah, and next one is actually pain. Yeah, pain, perianal pain, discomfort. This can be very distressing to certain patients and all as well. Yeah, and it's something, pain per se, without finding a diagnosis, it could be a condition as well, and it's something that's very difficult to manage to an extent. Yeah, some patients may come in with itching or irritation of the perianal area. Yeah, they can always complain saying that I always feel itchy. I need to keep on putting lotion. Need to scratch. So this is always itchy, things like that. So there are a lot of things that we need to think about when it comes to this kind of complaints and all as well. And or some people may complain saying that I feel like something is coming down from the anus. Yeah. Then again, we have to look into whether there is something that's coming out. Can we push it back? Is it always there? And how is it? So it's all boils down back to a physical examination later. But and the last but not least, some of the things that should also come in with discharge. Discharge, we're talking about pus, pus or purulent discharge that's coming out from the anus or around the anal area, around the anal area. So when you talk about common problems that can, with all the presentation that I talked about earlier, it's very, as I said, it's very broad. So it can be a lot of problems, such as could be either perianal abscess, fistula-in-ano, anal cancers, rectal cancers, anal fissures, cryptitis, just because of could be just simple enlarged papillas, incontinence, obstructive defecation syndrome, hemorrhoids, pilonidal sinus or cyst, proctitis, proctalgia fugax, pruritus ani, rectal prolapse, mucosal prolapse, rectal seals, warts. These are so many. I can keep on going on for another few more pages of things, but what I've listed down here, these are some of the things that a bit more commonly seen, but because due to interest of time, if you want me to cover the entire topic, is completely impossible to cover within the next 45 minutes or so. So we'll be just going to focus on a few things, talk about a bit of perianal abscess, fistula-in-ano, anal fissures, hemorrhoids, and rectal prolapse. Of course, anal cancer, rectal cancer is a topic, is a very commonly seen, but it's a topic by itself. I didn't cover that very much, but these are the things I'm more focusing on the benign cases, conditions this time. So the most important thing when patient comes to you, any of the problems I mentioned earlier, is actually a very good history taking together with the physical examination, inspection, digital rectal examination, and if possible whether need to do a proctoscopic examination to confirm. We have seen a lot of conditions that a lot of treatment has been done purely based on the history of what patient tells you, and the diagnosis can vary from something that's just a benign to something really to a malignant cases and all like that as well. So it's very important for us to properly examine the patient, and before we come out to conclude a diagnosis what this is actually is all about. So one of the things, the first thing that basically I'm just going to talk about, roughly go through, is actually the perianal abscess. Perianal abscess is something, basically it's an infection that usually starts in the crypts of Mognani and extends along the areas that relate to the anal glands. It could be into the intersphincteric space, and where it forms an abscess. This then subsequently can go down to different directions, which I will show you all an image later. And this patient can mainly present to you with acute pain at the perianal region. Pain, it could be either perianal or with inside the anus. Patient can tell you it's very severe pain inside the anus. Why inside the anus, I will tell you all later. Basically it's a severe acute pain associated with fever, abscess, right? As any abscesses, patients will have fever, or tenderness, swelling, and of course if the rupture the swelling ruptures, then they'll have discharge. And patient can tell you the pain subsided completely the minute the abscess ruptured. So these are the conditions of the perianal abscess, and these are just imaging, shows that how different presentations of how perianal abscess can form. This usually can go up to the perineal region, can extend go up to the gluteal region as well. So sometimes it might not be that simple to an extent. Yeah. So most of we know that perianal abscesses occurs roughly about 60%. So when I talk about perianal abscess, we're talking about basically something that's very low down. But when you talk about abscess alone, it also compromises a lot of other abscesses that forms other parts of the anus or perineal region. Yeah, talking about ischiorectal abscess, intersphincteric abscess, pelvic or supraelevator abscess. Of course, supraelevator abscess is very rare, less than 2%. But when we talk about ischiorectal abscess, you see it's actually quite high, significant numbers, almost 30%. It's basically talking about almost 1/3 of the cases. So ischiorectal abscess, most of the time you see the patient might not be able to see the swelling. Patient won't have the swelling because the abscess is very deep inside. The swelling usually will present only in a later stage when the abscess extends all the way down to the skin. But in the early state of abscesses or ischiorectal abscess, the abscess might not be able to be felt and all as well. So it's very much important to have a high index of suspicion in these kind of cases, whether especially when patient has got fever, severe pain, the deep-seated abscesses need to be ruled out. Yeah. Another place is actually intersphincteric abscess. This intersphincteric abscess is another thing as well. Is also something that is not easy to diagnose clinically. Sometimes one of the way for us to have a high suspicion of high index of suspicion for intersphincteric abscess is actually when you do a digital rectal examination. Yeah, when you palpate lateral part of the anal wall, the tenderness is a bit more on the other side, so you know that something is actually going on. And how do we confirm that? I will talk about it later, but most of the time you need some form of imaging. One of the commonest imaging that we do bedside is actually the endo-anal ultrasound. I'll share with you all a bit later on that part. But yeah, so a simple perineal abscess can be easily managed. It can be easily, but when it comes to ischiorectal abscess, intersphincteric abscess, or supraelevator abscess, it's something that's a bit more complicated, and it needs a bigger incision and drainage to relieve the abscess. Yeah, okay. So as we all know, the basic treatment for abscesses are drainage. A good adequate drainage of abscess is very important. A simple perineal abscess that comes to general practice, I think the drainage can be done even in the general practice setting itself. But some of the principles when it comes to a proper drainage is basically you should have adequate size or opening of the wound, and make sure the wound doesn't close prematurely. Yeah, when we do an incision drainage, drain the abscess, we expect or we intend with the intention that the granulation happens from the base of the wound. So if the wound or the skin closes prematurely, the abscess recollects back inside, and then the same problem starts back again. Yeah, this is thing. But when it comes to ischiorectal abscess, then the drainage side is a bit more difficult, because we really need to drain on side. Sometimes the ischiorectal abscess could also connect post-anally to the other side. So sometimes we have to make sure that this not connected, forming what you call this a horseshoe abscess or something like that as well. Yeah. So of course, after the incision and drainage of these abscesses, antibiotics is must. A flagell will do, or something that Unison to cover a bit of gram-negative together with anaerobes is very important. Yeah. So in our settings, usually we'll either give cefroxime and flagell, Unison. Yeah, Unison covers both, so you don't have to add another tablet talking about a flagell on top. Or sometimes just a simple flagell is also will be adequately enough. But if you are incising on the skin per se, then definitely need to cover a bit more. Yeah, and another thing that is very important when patient comes to us with a perineal abscess is, and most of the time we have a very high index suspicion whether is this the early signs of what we call as Fournier's gangrene. Yeah, another word basically necrotizing fasciitis. This is when you examine a patient where there's an abscess. It's good to examine the surrounding skin around that area, to the scrotum and to the to the groin as well. If you feel there's a crepitus, yeah, if you feel there's why this is a crepitus, I can feel the air locules, and the tenderness or the redness of the skin extends beyond the area where you think the abscess is, then the high index of suspicion should be there for when you talk about Fournier's gangrene. If the Fournier's gangrene is not presented early, yeah, these patients might need a very extensive debridement. So the only way to actually to properly heal the Fournier's gangrene is actually to completely excise the whole area which is affected and leave it bare and let it granulate from up. Yeah, and this needs urgent referral to a surgical center. And leaving this without treated can actually cause life-threatening condition as well, because these patients can go into very severe sepsis, then later can go into multi-organ failure and so on as well. Yeah. So when you talk about perianal abscess, most of the time, I would say roughly about half of the time, perianal abscess are usually associated with some we call it fistula-in-ano. Yeah, so it's actually an epithelialized tract, yeah, communicating between the anus and rectum to the skin around the anus. Yeah, so it's a tract, it's a proper epithelialized tract communicating right from the skin going into the internally into the rectum or anal canal. Yeah, and most of the time it starts, as I said, starts with anorectal abscess, it ruptures and then it forms as a tract over time. Generally, most of the time when you talk about why this happens is basically because of the cryptoglandular theory, which is the infection in the crypts and glands around the anal canal. But sometimes it could also be secondary causes of why this fistula happens. Yeah, this is something that we have to look into and be a bit more suspicious. Whether the fistula that we are seeing, is it just a simple fistula, or is this a fistula that associated with TB, inflammatory bowel disease, especially Crohn's disease, or is it something we are talking about malignancy here, or venereal diseases also could lead into what you call this as the fistula-in-ano. Yeah, okay. And one of the things that we talk about fistulas, I think we can't get away from this Good-Sal's rule. If you lie a patient on a lithotomy position, yeah, with the coccyx at the posterior part, yeah, and the urethra is on anterior part, and we draw imaginary line, okay, most of the time if the opening is anterior to the imaginary line that you draw, the tracts are usually straight tracts opening up into the anal canal. Yeah, but whereas in the posterior part, most of the tracts will actually circular and converge usually at the 6 o'clock area. This is not a 100% rule, but generally applies most of the fistulas. But there are some exceptions for this kind of rule, is especially when your external opening is very far, more than 3 centimeters from the dentate line, from the anal verge, or the fistula is due to some secondary causes such as I talked about earlier, TB, yeah, malignancy, Crohn's, and so the Good-Sal's law doesn't really apply much. This is important for surgical part of view when we talk about the surgical intervention, how the tract need to be excised or need to be targeted later. One of the important classification when it comes to fistula-in-ano is types of fistula, how the fistula tract transverses down from the anus down to the skin. So the most commonest fistulas, and it's very simple, easy, is actually intersphincteric fistulas. Yeah, intersphincteric fistulas, we talk about, basically you look at this one here, the tract goes between the internal sphincters, go to in between the internal external sphincters and comes down through that. So basically this is a simple intersphincteric fistulas. Yeah, and so next one is actually a transsphincteric fistulas. Transsphincteric fistula is it transfers both internal and external sphincters and comes down as a fistula after the opening in the anal canal. Yeah, but a bit more rarer fistulas such as suprasphincteric fistulas or extrasphincteric fistulas, but these are rarely seen, but these are also the fistulas that needs is not easy to manage or easy to handle. The recurrence is very high if it's not done properly in the first setting itself. So even any other fistulas, intersphincteric or suprasphincteric fistulas, if the first surgery was not done properly, the recurrence rate can be quite high. In the best of hands, sometimes the recurrence can go up to almost about 10 to 15% by itself as well. It depends on the procedure that's being done. Yeah. Okay. And when you treat a fistula-in-ano, things that always runs in a surgeon's mind is a dilemma whether how much to do for the fistula. The things that we always balance between these two things is actually the recurrence of the fistula and also the incontinence the patient goes through if the certain procedures are done for these patients. We can always make sure that the fistula completely doesn't completely excise the whole tract all the way from outside up to the anal canal. By end of the day, patient will end up with a severe incontinence, which defeats the purpose, isn't it? So patient probably will have a much more poorer quality of life because of incontinence, but his fistula probably would have been healed, but it's not something that we want. So it's something that we have to balance in between the recurrence of the fistulas as well as the incontinence the patient goes through after the surgery. Okay, so because of this, it's very important to do at least a simple imaging for patients before we put a knife on these patients. Yeah, most of the time, a simple fistulas we do endo-anal ultrasound. Yeah, it's a probe that is inserted into the anus. Look at the anus in a 360 degrees. I will show you all the images later. To 360 degrees, and we can also reconstruct the image into a 3D image to actually see how the fistula tract is transversing around the sphincters. Yeah, and most of the MRIs are usually we reserve for more complex cases, usually such as recurrent fistulas, multiple openings, yeah, complex fistulas, extrasphincteric or suprasphincteric fistulas, or as I said, the fistulas because of secondary causes. So in these cases, it's very difficult to assess these fistulas purely by endo-anal ultrasound. So you definitely need MRI to supplement our examination or bedside investigations at the time. Yeah. So this is an imaging of two imaging. The first one what you see is actually an MRI. You'll be able to nicely see the fistula over here, which is transversing both the internal, then goes into the external sphincters. External sphincters and goes into the internal sphincters and opens into the anal canal of the other side. So this is a advantage. So if there are multiple tracts, you should be able also to see how the tract actually transverses and opens up into the anal canal. And this is another example of an endo-anal ultrasound on the other side. Yeah. So when you do endo-anal ultrasound, we usually inject hydrogen peroxide. Yeah, so that the tract that you see becomes bright over here. So with the reconstruction videos, so we roughly to be able to see how the tract actually transverses. Is it a single tract? Is it a multiple tract? Yeah, how is the opening? Where is the opening? Yeah, and we also probably to some extent be able to see if there's an internal opening, how far is it from the anal verge, how much internal sphincters are involved, how much internal sphincters, if at all we need to cut off the sphincters, can we cut off the sphincters, and is it okay to cut off sphincters without patient having significant incontinence after that. So it's very important to assess. Yeah. So if you look at the images here, what you see as a dark circular line over here is actually your internal sphincters. Yeah, and this is actually the internal sphincters, whereas outside a bit more hypoechoic is actually the external sphincters. Yeah, this is your anal canal over here. Yeah. So again, the treatment of fistulas in anos, it always starts again big from the basis. If there's abscess, drain the abscess, control the fistulas. So I always tell my trainees or doctors that when you do a simple fistulas, even perianal abscesses, look for a fistula opening if at all there's a fistula opening. Yeah. Of course, we don't do a definitive surgery for the fistula at the same setting where there's an abscess is. Usually we'll settle the abscess and then go in for the definitive surgery for the fistulas. From our experience, we realize that when you do a definitive surgery for the fistulas at the setting of an abscess when inflammation is going on, the risk of recurrence or breakdown is much more higher, and patient probably will come back to you because of non-healing wound. Yeah. So basically, the first step, as I said earlier, is actually drain the abscess. We drain the abscess, we control the infection. When we say we drain the abscess, it could be just incision and drainage, or sometimes what we do, we put in a siton. Yeah, siton is like a rubber kind of a thread that transverses through the fistula into the anal canal, comes out and is tied, so it keeps the fistula tract patent all the time. When the tract is patent, so whatever abscesses that are formed inside will actually be drained out easily. If you ask a patient that has got a fistula, he'll be able to tell you a very clear-cut history saying that you will have discharge coming out, then suddenly the discharge stops, the wound outside heals, he feels better, then over time he started feeling pain again, whether the abscess has started collecting, then it ruptures, pus relieves, comes out, he feels better, and then it's a cycle that will go on and on and on. This is a typical history the patient will come to you with, especially when you see this got a fistula-in-ano. Yeah, and antibiotics are important as an initial phase at the time of abscess, but antibiotics alone will not heal the fistula. Yeah, because these tracts are orally epithelialized, yeah, with the granulation tissue, so it will not going to heal just with antibiotics alone. So that's why we need to do a proper definitive surgery after that. Okay, when is the best time to do the surgery is all depends on the patient per se and how bad is presented with the abscess at the time. I usually will wait for the tract to properly mature before we actually do a proper definitive surgery. This purely because it's easier to deal with the very mature tracts or ligate the tracts, or anything it stays. Otherwise, the immature tract slips out easily, tears easily, and then again the fistula will come back because you're not ligating or tracking the tract properly at this time. Yeah. So some of the options we have: fistulotomies, fistulectomies. I think you all know, laying open the fistula tracts. But what are the newer techniques of fistula surgeries now? Is basically we talk about lift. Lift is we talk about ligation of intersphincteric fistula tract. Ligation of intersphincteric fistula tract. Then we have laser surgeries for fistulas. We have video assisted fistula tract surgeries, WAFT, and a few other things, actually fibrin glue or plugs. We don't really use fibrin glues or plugs. Of course, these are very least invasive procedures, but it's expensive and the recurrence is very high to a certain extent as well. Yeah, can go up to almost about 30 to 40%. And when we do this fistula surgery, and one of the last which I didn't write down here is actually the endorectal flap, advancement flaps. So when all the other treatment fails, and then most of the time we have to combine any of the procedures together with the advancement flaps to close off the internal openings. Okay, so this is an example of if you look at the image on this side, yeah, this on the search media is where your fistula with the laser fistulas. Yeah, so when we do laser surgery for fistulas, we always put in a siton first. Yeah, siton we drain the abscess, because when there's an abscess in the tract, the laser won't work very well. So we need to put in a siton, let the tract mature properly. Then you put in a siton, yeah, all the way up from the skin up to the opening inside the anus. Yeah, by doing this, when you pull out the laser probe slowly, it burns the tract, yeah, and closes off the tract indirectly. Yeah, and the recurrence for this procedure is almost roughly about 15 to 20% as well. Yeah. Then one thing that we commonly do nowadays is actually the procedure on this, where you see ligation or intersphincteric fistula tract. Yeah, we go in between the internal and external sphincters, find the space in between the two areas, look for the tract and ligate the tract over the other side. Yeah, and leave it. And sometimes what we do, the outside tract, we just claw out the tract outside here. Yeah, so indirectly this is one of the sphincter preserving techniques of fistula surgeries. Yeah, and what you see down here is actually what you call this a video assisted fistula tract surgery. This what you put in inside is a small microscope camera, yeah, with a diatomy at the tip of the probe. So you are actually looking at the tract, irrigating the tract while you're pulling it out. Slowly you are diatomizing the tract, right? And with the hope that it will close off the tract thing. Yeah, okay. And yeah, so that's basically a bit of fistulas, and as I talked about earlier, these fistulas need to be handled very carefully, because if first surgery is very important, not surgery that was not done properly in the first surgery, the recurrence rates are very high, and sometimes to going back to do repeated surgery sometimes is not easy as well. Yeah, and the next commonest things that seen in primary care is actually hemorrhoids. Yeah, hemorrhoids are basically it's normal for everyone to have hemorrhoid tissues. Yeah, these are part of the normal anodome cushions around the anal canal. Yeah, if you they are not veins, but they actually kind of sinusoids. Yeah, if you look at sinusoids, they are like a group of veins that intermingle, like a network of veins. Yeah, and usually provides for 15 to 20% of the resting anal pressure, and it feeds a vital sensory information when you wanted to defecate at the time. So cushion means it also gives an extra impact in the help of continence for the patients as well. So there are usually about 3 main cushions, which is at about 3 o'clock, 7 o'clock and 11 o'clock cushions. Yeah, and why do patients develop, as I said, patient hemorrhoids could be normal. Why do hemorrhoids gets bigger for certain patients, and why do they present with symptoms? Yeah, it could be because of constipations or straining when they exert the pressure a bit more longer. Yeah, so it gives the veins gets more engorged. Yeah, it's just not just constipation alone, but even diarrhea itself can actually cause patient to have hemorrhoids, especially if you have simple hemorrhoid, it can become much more bigger and prolapsing out as well. And usually this happens in patients who actually take very low fiber diet. Yeah, and elderly patients to a certain extent as well, especially in your muscles in the body becomes much more weaker, because so indirectly it gives the hemorrhoids to be bulged out as well. Pregnancy is the same thing, because it's the pressure increase in the intra-abdominal pressure at the time, and obesity. Yeah, these are all the risk factors for patients actually to develop hemorrhoids. When we say hemorrhoids, there are 2 things. It could be either just a pure internal hemorrhoids, yeah, or it could be a mix of internal and external hemorrhoids. So if you look at the image over the other side, you see the veins and the sinusoids over the other side. The hemorrhoids that's above the dentate line, these are all is actually called internal hemorrhoids. Yeah, whereas the hemorrhoids that actually you see distal to the dentate line, mostly these are actually called the external hemorrhoids. Sometimes this internal hemorrhoid could also extend all the way down, becomes a mixed hemorrhoids. Yeah, okay. And hemorrhoids, we always put them into grade 1 to grade 4, basically looking at the severity of a prolapse and things like that. Yeah, grade 1, usually a hemorrhoid patient comes to you with the hemorrhoid problems. They say, I'll just bleed. When you examine, you'll see a small hemorrhoid, yeah, which doesn't prolapse. Yeah, it's just there. You see a cherry red spot. You see this is where it bled recently, but it doesn't prolapse. So there's no symptoms of patient history of prolapse. Yeah, whereas grade 2 is a hemorrhoid that prolapses out, but it spontaneously reduces back by itself. You don't need a manual someone to push the hemorrhoids back. Whereas the grade 3 hemorrhoids are usually those hemorrhoids that need manual reduction. Whereas the grade 4 are those hemorrhoids that you cannot be reduced. It stays outside much more longer and all as well. Okay, so grade 1 hemorrhoids are simple. Basically, it's just because patients have got bleeding. Yeah, there's no symptom per se. There's no much intervention needed. Most of the time, you just stop the bleeding. One of the ways to stop the bleeding is actually rubber band ligation, which I'm going to talk about it later. And this patient probably just need lifestyle modification and dietary advice after that. Yeah, whereas grade 2, grade 3, and grade 4, most of the time they need some form of intervention. Yeah, okay, and as I said, this is very important because I'm putting up this statement because we see a lot of these patients coming to us. Hemorrhoids are actually diagnosed. We have to diagnose these patients based on clinical assessment and also proctoscopy. Yeah, just by physical history taking, labeling patient hemorrhoids, I think we can miss a lot of things. Yeah, So it's very important to examine a patient before we label them these are purely hemorrhoids. Why we say that is we have to make sure that we're not missing out malignancies. We're not missing out malignancies because we have patients been telling us, they've been seeing people, doctors outside and being treated as a hemorrhoid for months, and then when they present late to us, when you just need to do a digital rectal examination, you see a huge tumor sitting there. If this was done much more earlier in the first setting itself, probably things could have been managed much more differently. Probably this patient could have been referred much more early. And when by the time 9 months, 10 months they present to us, sometimes it could be a metastatic disease already. It's very sad for the patient at that time. So when you talk about management for patients with hemorrhoids, always divide, as I said, conservative management, interventional management. Dietary modification, stool softeners, Deflons. Deflons are the medication that we usually give, is what we call as a phlebotomics. If you look at US, they don't really use that as a medication, they use that as a supplement to a certain extent. But in Malaysia, we use that as a medication. It's actually a phlebotonic which strengthens the vessels of the veins, so it doesn't bleed that easily to a certain extent. And makes the vessels a bit more stronger. Sitz bath, usually some patients with hemorrhoids will have a bit of perianal itching and irritation, so sitz bath usually will help to ease these symptoms as well. And interventions, the most basic simple interventions is actually rubber band ligation. Rubber band ligations are usually done more for grade 1, grade 2 tumors. And we'll talk about with the images after this, but these are the things that what are the options available. This is an example of rubber band ligation. The one you see up here is what we call as a suction ligation, rubber band ligation, where there's a suction connected to a probe. You put in the suction over the hemorrhoidal tissue, and it sucks the hemorrhoidal tissue inside, and you release a small band. So this band will sit up here. Over time, it will go into necrosis, and the hemorrhoids will actually drop off. Whereas the older system is you have a forceps that goes through here. You put this closer to the thing, you pull the hemorrhoid tissue, and then you release the band, which we don't know. Not many centers do this anymore. But more people are moving on into a suction band ligation. It's important for us to know that when you do a rubber band ligation, it should be ligated only for hemorrhoids above the dentate line, not for the hemorrhoids below the dentate line. As I said earlier, the nerve innervations of the anal canal above the dentate line is by the autonomic nerve, so patient don't feel any pain. If when you do a rubber band ligation, when patient screams or shouts in pain, you know you have banded an external hemorrhoid rather than internal hemorrhoid. So it's very important not to band external hemorrhoids, because patient can actually really scream in pain, probably will be cursing for the rest of their lives. And the next is actually laser hemorrhoidplasty. This is another new technique that is being picking up nowadays, a minimally invasive approach for hemorrhoidplasties. These are usually good for grade 2, early grade 3 hemorrhoids, where a small incision is made. You can see the laser probe over the other side is inserted in, and this will actually burn off all the hemorrhoidal vessels. So when you pull out, so it contracts the tissues around that and makes the hemorrhoidal tissue disappear. This is an example how the hemorrhoidal fiber, laser fiber, is actually introduced into the hemorrhoidal tissues and burn off the tissue while it's being pulled out during the surgery. And there's another thing which is being done a bit more often as well, which is called stapler hemorrhoidectomy. You can call this hemorrhoidectomy or hemorrhoidpexy as well. What it does is basically you are taking off. This is the stapler that we use for the stapler hemorrhoidpexy. You put in the probe. Can you see the hemorrhoidal tissue drops in significantly inside, and when you tighten this, these tissues get stuck and get stapled off. This is the donut that we get once the hemorrhoidal tissue has been taken out. And when this hemorrhoid, one of the complications of doing a stapler hemorrhoidectomy is actually the stricture, anal stricture, because fibrosis or granulation around the staplers. sometimes can cause a bit of stricture. So it's very important these patients are actually seen in a clinic every week after the procedure, at least to do a proper digital examination to break any fibrous or early stricture formations that is happening at that time. Yeah. And this another thing is hemorrhoid ligation with a Doppler guided, not very oftenly done because the probe is expensive and the results are not that much different as well. So with the presence of the Doppler, you look for the artery that supplies down there, and then you ligate the artery. And once you ligate the artery, then you do a recto-anal repair. Basically, you do a pexy of the hemorrhoidal cushions all down there after that. Yeah, and this is an image of open hemorrhoidectomies. Open hemorrhoidectomies are usually we reserve for emergency cases when it's a thrombosed hemorrhoid or prolapse hemorrhoid cannot be reduced. Yeah, then we usually will go for open. When do open, also there are two ways of doing it. Yeah, whether you close back the skin or you leave it open and let it granulate from inside. When there's a component of infection at the time of hemorrhoids, irreducible hemorrhoids, you usually will leave the skin open, let it granulate. And it's very important when you do hemorrhoidectomies to leave some tissues in between the anal canal, normal mucosas. If the whole area has been excised, you don't leave any tissues in between. Also another problem, the patient actually can go into stricture or anal stenosis. Yeah. So another thing about problems that we always see is actually anal fissure. Yeah, anal fissure is actually a linear tear in the anal mucosa, and most of the time it actually happens in the posterior part of the anus. Yeah, it also can be seen anteriorly in females because of the childbirth. But if you see a fissure is more on the lateral aspects or other places, then we have to really think whether this fissure is because of secondary causes. Yeah, and one of the reasons why this fissure happens mainly is because of the trauma followed by sphincter tone. Yeah, when there's a trauma, a tear happens, automatically your sphincter becomes more tighter. Yeah, it becomes the tone of the sphincter becomes increased, and when the tone is increased, indirectly causes a bit of ischemia to that area, and it becomes more worsened after that. Yeah, so this is an example of fistula you see, and this is a picture of a chronic fistula, chronic fissure. You will most of the time will be able to see a papilla when you do a examination, and sentinel skin tag. Yeah, sentinel skin tag. So there are two things: acute fissure, chronic fissure. Any fissure that you see a patient presents to you within 6 weeks, less than 6 weeks, is called acute fissure. Okay, this time patient probably will have severe pain. You might not even be able to examine this patient. Yeah? So if you think this patient has got severe fissure, do not do a digital rectal examination, because patient will also be screaming in pain. Most of the time when you happen to see, you just stretch the anus, sometimes you'll probably be able to see a small linear tear over the side. Yeah, and if you do an endoanal ultrasound examination, most of the time sphincter size are almost the same because it's still something very acute. Yeah, but in a chronic fissure that stays more than 6 weeks, so by the time the pain becomes much more lesser for these patients, you will be able to see some granulation tissue at the base of the tear, or with the presence, I said earlier, skin tags and hypertrophic fistulas, papillas. Yeah. So this is an example, just a simple fissure tear, and then there's a chronic fissure tear on the other side. Yeah. Medical treatment in acute phase, we don't operate patients in the acute phase. It's purely on medical treatment. In terms of analgesia, medical treatment such as GTN, all-deal thiazide cream. Basically, these are actually to relax the sphincters. Yeah, advise patient a bit more on high fiber diet, a bit of lignocaine gel before he passes motion, so that it's a bit more lubricated and easily for the stools to come out. Yeah, and we in chronic phases, if patient is okay, we can actually continue the medical treatment. Yeah, another option is actually botulinum toxin to relax the sphincters, but this is something that need to be repeated every 6 months. Yeah, we hope that with the botulinum toxin, with 6 months, hopefully the pressure is lesser, the fissure heals much more better as well. Surgical intervention is an option for patients with the severe symptoms. Most of the time is actually a lateral sphincterotomy is done. Basically, what I will show you the picture later. what we are worried is actually we're going to cut part of the internal sphincters, yeah, and what we are worried about incontinence, and the risk is almost about 15% for this group of patients. Yeah, this is an example how we do lateral sphincterotomy. Yeah, so you identify the internal sphincters, and then you cut off the part of the internal sphincters so that the sphincter relaxes and patient don't have so much of increased tone and pain as well. So the pain that they feel is purely because of increased anal tone, the sphincter tone, and indirectly which is causing the ischemia at the same time. We can either do an open technique here, or this is what we call as a needle technique, scalpel technique. Just put in the blade and cut off the sphincters. And it's also very important to do an endoanal for this ultrasound for these patients to assess how long is their internal sphincters. Yeah, we usually I would not cut a sphincter more than 1/3, more than 1/3 of the length of the sphincters they have. And it's very important to also to see how long is the fissure. Okay, the sphincter that we cut has to be slightly above the level of the fissure internally. Yeah, if the fissure goes very high up, you need to cut more muscle. Again, back to square one, when you cut more muscle, incontinence is a very big issue. Yeah, so it's something that need to be balanced over here as well. Last but not least topic that we're going to talk about is actually the rectal prolapse. What is the rectal? It's actually abnormal movement of the rectal mucosa down or through the anal opening. Yeah, it protrudes down. It can be either just a mucosal prolapse or full thickness prolapse, which I'll show you the image how to differentiate these two. It could be usually associated with increased age, patients with chronic diarrheas, constipation is the same thing. But what we don't see in Malaysia, this part of the world, is just celiac disease or cystic fibrosis. Yeah, this is very rare, but these patients are more higher prone risk to have rectal prolapse. Also, those patients with the trauma to the pelvic floor because of a childbirth, especially those who have multiple children, multi-gravids. Okay, and if you see the picture of partial thickness of mucosal prolapse, the sphincter stays in the same place. So what you actually see prolapsing out is only the mucosa that comes down, which can easily be pushed back up again. But when you talk about full thickness prolapse, even the sphincters, everything are coming down together with the prolapse bowel. Yeah, so the full thickness rectal prolapse. Yeah, so an example of it, this what you see here is actually the full thickness, where you see circular donuts over here. When you see things like this, you should be suspicious of whether this is actually a full thickness rectal prolapse. But if you don't see a full thickness, just a partial tissues coming out, most likely is just a mucosal prolapse. Why is important? Because the management also differs to a certain extent. Yeah, as I said, the treatment at the general practice, when the patient presents to you, try your best if can. Bit of analgesia, reduce the swelling as early as possible, before the edema sets in. Once the edema sets in, sometimes it's not easy to reduce back the prolapse rectum. We have to treat the underlying cause why the prolapse happens. Is it because of the diarrhea, constipation? So most of the time we do surgical interventions only when it's a recurrent problem for the patient. It's just not with the one-off thing. So if it's a recurrent and causing a lot of problems to the patient, then definitely surgical intervention. What surgical intervention is the best? We have abdominal approach or perianal approach. If elderly patients, usually we don't try to do laparoscopic or abdominal approach. We go into the perianal approach, which is much more simpler. This is an example of the rectopexy. What we talk about is actually a abdominal approach for prolapse. So what we do is the rectum, it's been mobilized and pulled up and sutured up here, so that the possibility of it coming down is much more lesser. Okay, but this is of course it's a bigger surgery, need much more advanced skills in the laparoscopic for us to do that. Doing an open surgery is not easy for these cases as well. And a perianal approach is basically you're looking at the prolapse that's coming out, you're cutting it off and then suturing it back, so that you're taking out a cuff of the tissue that's being prolapsed out. Yeah, this is the perianal approach usually reserved for more for elderly patients, not fit for major surgical intervention. Yeah, so it's much more beneficial for them. Yeah, okay. Yeah, I think that's the end of the talk for today. Basically, as a conclusion, proctology problems presents to general practitioner could be sometimes just an early signs of malignancy, especially cancers. Yeah, so a very good proper examination, high index of suspicion is extremely important. So take the opportunity to advise your patient for cancer screening as well. Yeah, if you think that something is not right, suspicious, advise the patient for cancer screening, especially when they're more than 50 years old. But if you look at Sabah, the 50 years old doesn't really apply. We have very young patients. So age by itself, I personally feel in Sabah is not something that first to say this is unlikely to be a cancer. Yeah, we had patients recently that operated a 12 years old boy with a cancer. So it's something that it can happen to everybody anytime. So something that we really need to keep in mind. Yeah, with advancements in the treatment, most of these conditions actually can be managed nowadays with a very minimally invasive techniques. So something that patients don't really have to worry so much. Yeah, though this actually what we talked about earlier is all a benign conditions, but they have got a very significant impact on the quality of life for these patients. Hence, I think a referral to a colorectal surgeon for the early and the best treatment is very important, for that the patient can actually continue with their normal activities after that. Yeah, we have a Facebook and Instagram, the flashes for colorectal surgery Sabah. You can actually mail us or messages, and anytime we can always reply you if any doubts. So we can we also put up some information over there for people to have a look. Just follow us up at here for further information on this. Yeah, with that, I'd like to say thank you very much. Thanks for being here with us tonight. Yeah. And back to Lucy.
Thank you so much, Dr. Krishnan. We will now go to the Q&A session. Thank you everyone for sending your questions to us. So let us go to the first question. Doctors, are you okay?
Yeah, yes.
Okay, so we go to the first question. This one is from Dr. Lee. Hi, Dr. Krishnan. Thanks for the detailed presentation. In what condition patient with hemorrhoid will benefit from Daflon, doctor?
Okay, most of the time patients with hemorrhoids, that will definitely is actually the patients that presents to you with bleeding. Yeah, if patient comes to you with the presentation of bleeding and you diagnose these patients with hemorrhoids, these patients will benefit the most. Yeah, of course, if you look at most of the literature studies, Daflon doesn't make that much of a difference, but we personally feel that this phlebotomics improves the tone of the vessels, especially the veins, and reduces the risk of bleeding for these patients. So we usually start patients on Daflon, especially those presents with bleeding, immediately after we do band ligation or after the hemorrhoidal surgeries. So these are the conditions that usually the hemorrhoids, when the Daflon will be useful. And when you start Daflon as well, they have high dose and low dose Daflons. Yeah, so when we first start initiate the treatment of Daflons, we usually will give a higher dose, which is roughly about 1 gram TDS for 4 days, 1 gram BD for 3 days, and then usually continue with 1 gram OD for 2 weeks to 2 to 6 weeks. Yeah, but most of the time the maintenance dose is just 1 gram OD for 6 weeks. Yeah.
Okay, next one, doctor. How do we differentiate prolapse internal hemorrhoid versus external hemorrhoid, doctor?
Okay, prolapse internal hemorrhoids, usually that's why it's very important for us to do a proctoscopic examination. When we do a proctoscopic examination, you will be able to see the hemorrhoids that's prolapsing out. It's actually coming out from above the dentate line. Yeah, and the external hemorrhoid per se is very difficult to reduce. Yeah, you cannot reduce external hemorrhoids, whereas your prolapse internal hemorrhoids, you can push this back into the anal canal. So once you push back the hemorrhoids back into the anal canal, when you do a proctoscopic examination, you will be able to see clearly that these hemorrhoids are actually coming above the dentate line. Yeah. So.
Okay, next one. This one is from Dr. Henry Ong. How do we treat external hemorrhoids that is painful during BO?
Okay, external hemorrhoids painful during BO is something that usually will most of the time if they are painful is actually because it's thrombosed. Yeah, just simple hemorrhoids usually won't be painful. It's usually painful because of the there's a component of thrombosis within the internal hemorrhoids. Sometimes when you see that, when you examine, when you be able to see a thrombosed tendinous part, we can actually make a small nick over the side, evacuate the clots over the thrombosed area, and this immediately will relieve the pain for the patients, yeah, in terms of rectal prolapse. Other than that, if analgesia, if the pain is not so severe and you don't want to make a nick, patient not keen for that, analgesia, it's good enough to control that to an extent with a bit of laxative or stool softeners. Yeah.
Okay, another one, doctor. This one is from Dr. Daljiet. Is it okay to undertake removal clots from external thrombosed clots in a GP setting, doctor?
Yes, I think it's safe. If it's a small hemorrhoid and the external hemorrhoid, I think it's safe to make sure we have a proper compression. I think sometimes what we do when we take a small nick, most of the time even patient comes to hospital, these procedures are actually done in emergency setting bedside. Yeah, so we don't really have don't use diathermy or anything. So it's just a small nick, evacuate and then compress. Sometimes we put in a bit of adrenaline pack over the other side, so that it helps in the to stop the bleeding. Yeah.
All right.
Yeah.
So I think that was the last question we have for today. Dr. Krishnan, do you have any last remark for our viewers today, doctor?
No, I think as I said, as my thing, very good examination is extremely important. Of course, all these problems are just benign if you think it's a benign. Of course, the risk of malignancy of these patients turning out to be malignant or cancer is very rare, but we don't want to miss this small array of cases. So do a proper examination before these patients are being labeled just a benign proctology problems. And thank you very much.
Thank you once again, Dr. Krishnan. To all doctors, please don't forget to scan the QR code at the end of this live by using your MMA Doctor Phone application to get your CPD point now. If you have any difficulties to scan the code, please click on the link for doctors only in the comment section to confirm your attendance manually. And to all the Gleneagles Hospital Kota Kinabalu staff who are watching this now, please don't forget to click on the link which is specified for GHKK staff only in the comment section for your training purpose. Please make sure you click the correct link for your attendance. And also, we have another online CME session with our resident orthopedic arthroscopic sports and joints reconstructive surgeon, Dr. Damalingam Mutia, on the topic of cartilage surgeries on 2nd of December at 6 p.m. Let me know if you are interested. We will share the details with you. We have come to the end of our online CME today. Thank you for watching and listening to us today, and see you next time.